This is Alan Jacobson, and it is my privilege to present the results of a multi-center United States evaluation of the iLine microINR point-of-care system when used by self-testing patients. The study investigators and institutions are listed here, along with graphics of the device utilized in this study, which was sponsored by iLine Microsystems. We have seen an ongoing evolution of point-of-care INR testing devices over the past several decades, since the original device, a KC-1A, was utilized back in 1982 by Heike Müller in Germany. The microINR point-of-care system is a further evolution of these devices, with advances in automatic strip lot identification calibration, minimum testing steps, reporting only in INR units, and most importantly, in my view, a further reduction in sample volume to a minimum of 3 microliters. A prior study has already reported the professional use performance characteristics of this system, so the current study is to document the results when utilized by self-testing patients on warfarin BKA therapy. The study consisted of a training visit followed by 2 clinic visits 2 weeks apart. At each of the clinic visits, both the subject and the professional staff would perform duplicate testing for a total of 4 fingersticks. Between visits, the subjects performed 2 tests at home each week. At the second visit, a venous sample was also collected for testing of hematocrit and for testing with a laboratory reference, an ACL Top 500 with Hemocil, Recomboplast, and 2G reagent. Subjects also completed an ease-of-use questionnaire with scores ranging from 1 being strongly disagree up to 5 being strongly agree for each ease-of-use characteristic. 117 subjects with different diagnoses and capabilities completed the study, but only 114 had complete data sets. Given the range of clinical diagnoses of the study subjects, utilizing a therapeutic range of 2.0 to 4.0, there was a 98% clinical agreement. Ease of use scoring averaged 4.7 out of 5. In Figure 1, we see regression analysis comparing self-testing subject results with professional staff results. There were 228 test pairs, and the R value is 0.955. In Figure 2, we see the regression results for the 114 PST tests that could be compared with the central laboratory reference method, and the R value is 0.943. Table 1 shows the predicted bias at potential medical decision points of low therapeutic, high therapeutic, and above therapeutic for both PST versus professional staff, as well as PST versus reference lab results. As expected, the 95% limits broaden at higher INRs, but are clinically satisfactory at 2.5% or less. Table 2 demonstrates the repeatability in the duplicate testing at Visit 1 and Visit 2, both when performed by subjects and by professional staff. Note the improvement by subjects from Visit 1 to Visit 2, from 5.9% to 4.9%, which is approaching the professional staff CV of 4.6%. There are multiple reference standards for determining acceptability of analytical agreement, and 3 of these are demonstrated on Table 3. Results from the current study, in the far right-hand columns, are well within all 3 of these standards. In conclusion, there is excellent analytical agreement between patients and professional staff, as well as between patients and the reference laboratory results. Subject reproducibility on duplicate testing is also excellent. The microINR point-of-care system further enhances the device options for patient INR self-testing, as well as professional use, and has reduced the minimum sample size down to 3 microliters while maintaining excellent patient satisfaction with ease of use. My thanks to the other investigators and to iLine Microsystems.